Nitrous oxide has been in continuous medical use longer than almost anything in your entire drug cart. People were inhaling it for fun at parties before anyone figured out it could stop surgical pain. What this actually is. Unlike sevoflurane or desflurane, nitrous oxide isn't a complex organic molecule. It's a simple inorganic gas, colorless, non-flammable on its own, but it will actively support a fire that's already burning, which is a genuinely important safety distinction in the OR. It's stored under pressure in blue cylinders, existing partly as liquid and partly as gas inside the tank. The molecule is small, and it has remarkably low solubility in blood, a blood-to-gas partition coefficient of about 0.46. That single number is going to explain practically everything unusual about this gas, so hold on to it. The strange potency problem. Here's the part that surprises people. Nitrous oxide's MAC sits around 104%. Since you obviously can't deliver more than 100% of any gas at normal atmospheric pressure, this means nitrous oxide, used alone, at sea level, cannot reliably render a patient surgically anesthetized. It's simply not potent enough on its own. So why does every anesthesia machine still have a nitrous line? Because what it lacks in raw anesthetic potency, it makes up for somewhere else entirely. Where the real value is. Nitrous oxide is a genuinely strong analgesic, disproportionately strong, actually, relative to how weak it is as a pure anesthetic. The analgesic mechanism appears to involve NMDA receptor antagonism, along with effects on the body's own opioid and noradrenergic pathways. It also produces minimal skeletal muscle relaxation, nowhere near what the volatile agents provide. But its most practical role in modern anesthesia is reducing how much of your other agents you actually need. Add nitrous oxide to a volatile-based anesthetic, and the minimum alveolar concentration requirement for that volatile agent drops meaningfully. The high-yield way to remember this drug: weak anesthetic, strong analgesic adjunct. Why it moves so fast. Return to that blood-to-gas coefficient, 0.46. Low solubility means the gas doesn't dissolve much into blood before saturating it. Alveolar partial pressure climbs quickly, brain partial pressure follows right behind it, and onset happens fast, within a minute or two. Turn the gas off, and the exact same principle runs in reverse. Nitrous leaves the blood and re-enters the alveoli rapidly, producing genuinely rapid emergence. Fast on, fast off. This is the pharmacokinetic signature of low blood solubility, and nitrous is about as extreme an example of that principle as you'll find. The concentration effect and second gas effect. Nitrous oxide is typically given at fairly high inspired concentrations. Because so much gas gets absorbed from the alveoli so quickly, the remaining gases left behind in the alveolus become relatively more concentrated, simply because the total alveolar volume has shrunk. That's the concentration effect. Now run a volatile agent alongside nitrous, and something useful happens. As nitrous rapidly leaves the alveolar space, it drags the volatile agent's alveolar concentration up right along with it. Nitrous uptake effectively concentrates whatever volatile agent you're running simultaneously. That's the second gas effect, and it's a direct, practical consequence of how aggressively nitrous gets absorbed. The concept that matters most: closed gas spaces. If you remember only one thing about nitrous oxide, make it this. Nitrous oxide is roughly 34 times more soluble in blood than nitrogen is. Nitrous blood gas coefficient, around 0.46. Nitrogen blood gas coefficient, around 0.014. Now, think about any air-filled space in the body that's mostly filled with nitrogen. A pneumothorax, a loop of obstructed bowel, an air bubble somewhere it shouldn't be. Because nitrous dissolves into blood so much more readily than nitrogen does, it rushes into that trapped air pocket far faster than nitrogen can rush out. More gas molecules entering than leaving means one of two things happens, depending on what kind of space you're dealing with. A compliant space, one that can physically expand, gets bigger. Volume increases. A non-compliant space, one that's rigid, enclosed, can't expand, builds pressure instead. This single mechanism explains a whole category of nitrous oxide contraindications. Where this actually shows up clinically. Pneumothorax, a classic example, and a dramatic one. 75% nitrous can roughly double the volume of a pneumothorax in about 10 minutes. Pulmonary bullae, or blebs, same expansion risk. Bowel obstruction with distended bowel loops. Nitrous will make that distension worse. Venous air embolism. If air is already in the venous circulation, nitrous will expand that embolus further. Pneumocephalus, intracranial air, which can occur after certain neurosurgical procedures. Middle ear gas spaces, intraocular gas bubbles, and even air-containing cuffs on certain devices. Nitrous can diffuse into and expand those too. The pattern to memorize. If there's trapped gas anywhere in the body, nitrous wants to make it bigger. The eye, one of the highest yield facts in this entire lecture. This deserves special attention because getting it wrong can cost a patient their vision. After certain retinal surgeries, retinal detachment repair, macular hole repair, vitrectomy, surgeons sometimes leave behind a gas bubble inside the eye to help hold the retina in position while it heals. If you give nitrous oxide to a patient with one of these bubbles still present, nitrous rapidly enters that bubble. The bubble expands inside a rigid enclosed globe. Intraocular pressure spikes dramatically. The retinal artery gets compressed, and the retina becomes ischemic. The result can be permanent vision loss. And here's what makes this genuinely dangerous in practice. These intraocular gas bubbles can persist for weeks after the original surgery. A patient coming in for a completely unrelated procedure, weeks after their retinal surgery, may still be carrying a gas bubble in their eye that you'd never think to ask about unless you specifically took that surgical history. Always ask about recent eye surgery. Always ask specifically about retinal procedures. This is one question that genuinely prevents blindness. The middle ear. Same underlying mechanism. Lower stakes location. Nitrous enters the middle ear faster than nitrogen can leave it, so middle ear pressure rises. This becomes particularly relevant when the eustachian tube isn't draining normally. That pressure has nowhere convenient to go. And there's a reverse problem too. Once you turn off nitrous, it diffuses back out of the middle ear rapidly, which can actually produce negative middle ear pressure on the way out. Diffusion hypoxia. This is the concept tied to stopping nitrous oxide rather than starting it. When you discontinue a nitrous infusion, large volumes of nitrous rapidly diffuse out of the blood and back into the alveoli. The same low solubility property that gave us rapid onset now gives us rapid offset. But that flood of gas leaving the blood and entering the alveoli transiently dilutes whatever else is in there, both oxygen and CO2. The alveolar oxygen partial pressure can drop temporarily, producing what's called diffusion hypoxia. The fix is simple, and it's genuinely standard practice. Give 100% oxygen for several minutes after discontinuing nitrous, specifically to prevent this transient dilutional drop in alveolar oxygen. Cardiovascular effects. Generally modest in healthy patients. Nitrous does have mild direct myocardial depressant properties, but it also triggers sympathetic stimulation, and that sympathetic activation tends to offset the depression, leaving blood pressure and cardiac output relatively preserved overall. The exception is patients with limited cardiac reserve. In that population, the direct myocardial depression can become clinically meaningful, since there's less compensatory reserve available to offset it. Respiratory effects. Like most anesthetics, nitrous can reduce tidal volume while increasing respiratory rate, and it blunts the normal ventilatory response to rising CO2 and falling oxygen. This respiratory depression becomes considerably more important when nitrous is combined with opioids, propofol, volatile agents, or any other sedative. The same synergy principle we've discussed throughout this entire drug series. PON. Nitrous oxide has been linked to an increased risk of post-operative nausea and vomiting, though how significant that effect is depends on how much exposure the patient had and the overall anesthetic technique used. For patients at genuinely high risk of PON, skipping nitrous can be a reasonable part of an overall risk reduction strategy. Respiratory effects. Like most anesthetics, nitrous can reduce tidal volume while increasing respiratory rate, and it blunts the normal ventilatory response to rising CO2 and falling oxygen. This respiratory depression becomes considerably more important when nitrous is combined with opioids, propofol, volatile agents, or any other sedative. The same synergy principle we've discussed throughout this entire drug series. PONV. Nitrous oxide has been linked to an increased risk of postoperative nausea and vomiting, though how significant that effect is depends on how much exposure the patient had and the overall anesthetic technique used. For patients at genuinely high risk of PONV, skipping nitrous can be a reasonable part of an overall risk reduction strategy. Vitamin B12, the other most important fact in this lecture. This is genuinely one of the highest yield, most distinctive properties of nitrous oxide, and it has nothing to do with the closed gas space problem we covered earlier. Nitrous oxide oxidizes the cobalt atom sitting at the center of vitamin B12, and in doing so, functionally inactivates it. That inactivated B12 can no longer serve as a cofactor for methionine synthase, so nitrous effectively shuts down that enzyme. Follow the downstream consequences. Methionine synthase inhibition leads to rising homocysteine levels, impaired methionine production, and impaired DNA synthesis, which can manifest as megaloblastic changes in rapidly dividing cells, and with significant or prolonged exposure, genuine neurologic injury. This is particularly dangerous in patients who already have vitamin B12 deficiency, or an underlying disorder of B12 metabolism. Their reserve capacity to tolerate this inactivation is already compromised before you've even turned the gas on. The longer-term consequences. With prolonged or repeated exposure, that B12 inactivation can progress toward genuinely serious pathology, megaloblastic anemia, bone marrow suppression, peripheral neuropathy, myelopathy, and broader neurologic dysfunction. All of these trace back to the same root cause: functional B12 inactivation, and the methionine synthase shutdown that follows it. This is exactly why nitrous oxide isn't a drug you'd want to use for extended continuous sedation, and why repeated recreational or occupational exposure carries real long-term risk. Pulling together the situations to avoid. The unifying principle, if there's trapped gas anywhere, nitrous wants to expand it. Avoid it in pneumothorax, significant pulmonary bullae, bowel obstruction or significant distension, venous air embolism, pneumocephalus, recent intraocular gas injection, certain middle ear procedures, and in patients with significant B12 deficiency or disorders of B12 metabolism. Why we still reach for it. Despite everything we've just covered, nitrous oxide remains genuinely useful. Rapid onset, rapid offset, strong analgesia, a meaningful MAC sparing effect, essentially no metabolism to worry about, relatively modest cardiovascular depression, and easy titration because you can adjust it in real time and see the effect change quickly. Used appropriately, in the right patient, without trapped gas anywhere in the body, it's a genuinely efficient tool. The high yield summary. Blood to gas coefficient. Approximately 0.46, fast on, fast off. Minimal alveolar concentration, approximately 104%, cannot provide surgical anesthesia alone at normal atmospheric pressure. It supports combustion without being flammable itself. It enters closed gas spaces roughly 34 times faster than nitrogen can leave. Compliant spaces expand in volume. Non-compliant spaces build pressure. Pneumothorax can expand very rapidly. Never overlook intraocular gas after retinal surgery. Always ask about it specifically. Discontinuation can produce diffusion hypoxia. Give 100% oxygen for several minutes afterward. It inactivates vitamin B12, inhibiting methionine synthase and raising homocysteine. Prolonged exposure risks megaloblastic and neurologic toxicity. It provides genuinely significant analgesia despite weak anesthetic potency, and it can contribute to postoperative nausea and vomiting. Pulling it all together, nitrous oxide, a gas too weak to anesthetize anyone on its own, yet still sitting on nearly every anesthesia machine in the country. Understand the low blood solubility, and you understand the speed. Understand the 34-fold solubility gap against nitrogen, and you understand every closed space warning on this entire list. Understand the cobalt chemistry in vitamin B12, and you understand why this isn't a gas you run indefinitely. Ask about recent eye surgery. Respect trapped gas wherever it's hiding. And never forget the 100% oxygen on the way out. I'm Anesthesia Buddy. Stay sharp. See you in the next one.